such a pleasure to have been asked to come to this beautiful city and this wonderful meeting to talk about something I'm very passionate about, which is improving outcomes in patients with advanced and recurrent ovarian cancer. And I'm so glad to see so many of you here today share that vision with the rest of us. But I'm really going to go in, here are my disclosures. So what I'm going to really talk about is sort of the cost of using niraparib as a maintenance. You've heard in the previous two discussions by Dr. LaRusso and Dr. Motter about the benefit that's been demonstrated in all subgroups of using niraparib as a maintenance therapy for platinum-sensitive recurrent disease. What I'm going to talk to you about is the adverse events that are seen when we do use niraparib in that population. We're going to look at the safety, and most importantly, or probably as importantly, we're going to look at what the patients say about taking niraparib in terms of patient-reported outcomes. And a lot of this was reported earlier in this meeting, so this will be a fairly high-level overview. So one of the first things to note about niraparib, especially when we're considering all of the agents that are available currently in the US and hopefully soon in Europe, is that niraparib is a little bit different. It's once daily dosing. So that's different. And the nice thing about that is that you can, when you're counseling patients about using niraparib, you can ask them to take it in the evening. If they, as you're counseling them about the potential GI side effects, particularly nausea, which we heard so much about today, they can take a preemptive antiemetic, take their niraparib 30 minutes later and go to bed and sleep through some of the side effects that they see. So this is a nice benefit to niraparib. Other niceties about niraparib is that there's really no impact of eating. So you don't have to take the dose on an empty stomach or with meals or an hour after sitting up for 3 hours. So, there's none of that craziness that we put our patients through. They can take the pill whenever they want to, as long as they're doing it at roughly the same time of day. There really aren't any known drug-drug interactions, which again, oral drugs, as we have more and more of these available, that's a big concern that we have to pay attention to, that we're not having concomitant medications interacting with one another and having adverse events related to those interactions. We don't see that here. There's really no indication to not use this in patients who have mild to moderate renal impairment. So that's to about a creatinine clearance of 30 at the lowest. Mild to moderate hepatic impairment, the drug appears safe. And I can't go into this in too much detail, but Dr. Motter actually just referred to it. There was a nice poster discussion on Saturday, that went through the experience of older patients who are treated with niraparib, those greater than or less than 70. When we look at the adverse events, so not only do they not have a different experience in terms of efficacy, there's really no difference in their toxicity experience either, which can be of concern. And so we have nice data as to the safety with that, and I would encourage you to look at that poster. So when we look at the NOVA trial, what do we see? So this is really concentrating on the toxicities that are sort of most severe, those grade 3, 4 toxicities, and these are the most common. We see thrombocytopenia in almost 34%. We see anemia in about 25%, neutropenia in 20%, and then fatigue, grade 3, 4 fatigue in 8%, and hypertension, and this is a unique related side effect of niraparib that you have to be aware of. We do see grade 3, 4 hypertension in about 8% of patients as well, and you can see the corresponding levels in the placebo group. Also important to mention, because this has been sort of the overriding concern with all of the PARP inhibitors and how we use them, is are we inducing later myelodysplastic syndrome or AML in these patients? And so that's been a big endpoint to look for in all of these trials. And here you see it was 1.4% in those patients who received niraparib and 1.1% in those who received placebo. So really no difference and no signal at this point that there's any sort of increased risk in this, with this therapy. So we do see some toxicities, and those are the ones that are important. The other important thing to know about experience on niraparib is demonstrated here. The dose modifications that are required in response to those adverse events really are concentrated in the first 3 cycles of dosing. And so you see here, starting from left to right, when you first start niraparib, everyone's at 300 milligrams once a day. At cycle 2, about half of your patients are dose reduced. So it's 50% now have come off 300 milligrams. At cycle 3, you're down to about 70% dose reduced, so 30% are still on 300. And then by cycle 4, you've made all of your dose adjustments, and you can see cycle 4 or month 4 and to the right of your screen, there's really very little variance. There's a little bit, but very little variance in the dose that your patient's on. And the point here is that the dose modifications made specifically for hematologic toxicities, once you get your patient on the right dose, it doesn't tend to be an ongoing event with a roller coaster of up and down platelets for the rest of that patient's experience on niraparib. Once you find the right dose, things stabilize and the dose modifications really become minimal. And so what we see is, again, this is a little bit of a build from the first slide I showed you with the adverse events. You see the adverse events, grade 3, 4 that I presented in the first column under niraparib. Once the result of appropriate dose interruption and dose modification is that starting at cycle 4, which is that middle column, and forward, you can see the reduction in recurrent high-grade adverse events. So thrombocytopenia goes from 34% to 2%. Once you've made appropriate dose modifications, neutropenia is down to 2%, fatigue is down to 3%. Anemia still remains a little bit of an issue at 16%, but you can see how much more manageable the toxicities become once you're on the right dose. And the other impact of appropriate dose modifications is that the dose discontinuation rate related to these adverse events is very low, in fact. So we may be modifying because of the platelets, but we're not discontinuing because of the platelets once we get patients on the right dose. So this is just one example of that concept. So this is thrombocytopenia. What this is showing you in the red box, I call your attention to this. We've sort of blown out the first month of therapy, so you have a data point for each week. And each data point is the change in mean platelets across the study. And so for thrombocytopenia, the mean time to get to the nadir is about 23 days, so you see at week 3. And the median time for recovery is about 10 days. And then the subsequent cycles all have one time point. And what you can see is, just like the dose modification bar graph I demonstrated, that cycle 2 and 3, we're still kind of finding the right dose for patients. But once you get to cycle 4 or month 4, the platelets are, the mean platelets stay the same for the remainder of the study, and they're very close to those patients who are on placebo. So again, you don't see these continued ups and downs of platelets. You can show the same data for anemia and the same data for neutropenia as well. Once you get patients on the same dose, things really stabilize. So these are just guidelines, and I would encourage you to look at the package insert for further details. But when you have thrombocytopenia or other hematologic adverse events, they're grade 1. You hold the drug until the platelets come back up to 100,000, or the ANC absolute neutrophil counts over 1,500. And then based on how low things got and how long it took to recover, you can restart at the same dose or dose modify it. If it happens again, you definitely dose modify. For hematologic toxicities that are grade 2 or higher, you're going to do the same thing. You're going to hold, restart when they are at appropriate levels at a dose reduction of 200 milligrams. If it happens again, you go down to 100 milligrams. If it happens again at 100, really you need to discontinue treatment with niraparib. The other important point is that when you're starting niraparib, you have to follow the labs weekly, because we are really intensively monitoring the side effects and dose monitoring appropriately. If you dose modify, you have to restart those weekly labs until you are sure that you're on the right dose for your patients. And then you can back off and do kind of per cycle labs. But we really do need to pay attention to weekly labs at initiation and at initiation of a modified dose. And so patients get nervous, and I think providers get nervous when we dose modify. They think they're on a less effective dose, they're less likely to be compliant, and they get worried. But what this data shows should be reassuring to you, that when you look at the dose that patients were on from cycle 4 on, so after all the dose modifications have been made, there's really no impact on efficacy. And so the patients, once they're dose modified per their adverse events, they're on the right dose for them, and we see a good efficacy. And that's in both BRCA and BRCA mutated and BRCA wild type groups. So I bet you're all sitting there wondering. I've just shown you an AE slide where we have quite a bit of hematologic toxicity. I've showed you that 80% of the patients who start at 300 milligrams are not at 300 milligrams at cycle 4. And I've shown you a survival curve that shows it just doesn't matter what dose I give. So why the heck am I starting at 300? I bet you're thinking that. And so here's the reason why right now we still recommend this. There is preclinical data that would suggest specifically or more significantly in BRCA wild-type patients, which is the majority of patients that we take care of, that in order to have a bigger cell kill, it's a preclinical model, you need a higher exposure to PARP inhibition, point 1. Point 2 is that the exposure of niraparib in individual patients at individual dose levels isn't closely tied or isn't perfectly associated with the dose. And so when you're at 300 milligrams, you have patients, and you can see this, who are at a very high level of exposure, and you have patients at a lower level of exposure. And those patients probably need to be at 300 milligrams. The rest of the patients who have a variance in exposures can be at lower doses and probably still get just as much PARP inhibition as needed to be efficacious for their particular disease. So there is a group of patients who need the 300. And the third thing, again, and this is what was also presented in the poster discussion session, is that this is a secondary analysis, but when we look in the BRCA wild-type patients at exposure, and it's just based on above or below the median, there does appear to be a trend for greater efficacy with higher exposures. And so based on that, we really do want to continue to start at the 300 level, but dose modify appropriately per the guidelines and not worry that you're decreasing efficacy with that dose modification, because you're probably not. The exposure is probably right where it needs to be. So take-home points with dosing are: start patients on maintenance within 8 weeks of completing platinum-based therapy. You can recommend, if you choose to, evening doses with preventative antiemetics. Make sure their counts are adequate to start. Weekly CBCs at initiation and at dose modifications. And then again, don't fret about dose modification, because you're not impacting efficacy when the dose modification is indicated based on adverse events. In the last few slides, I want to just give a high-level overview of what Dr. Amit Oza did a wonderful job presenting in the oral presentations Friday afternoon. And this is the patient-reported outcomes for the NOVA trial, because this is key. If we're improving progression-free survival, but patients feel terrible, then we haven't done a great job. And I think this is reassuring data. So there were 2 measures used in the NOVA trial. One's the EQ5D5L, which is 5 domains that were tested. And the second is the FOSSI, which is the Ovarian Cancer Symptom Index, which is an 8-item measure where patients report on a Likert scale if they had the symptom and how severe over the past 7 days. And it was done at baseline, every 8 weeks, and then once you came off study. And so what we see on the left-hand side, you see the CTC-AE reported adverse events, hematologic adverse events, kind of what I just presented to you earlier. And on the right-hand side, you see the impact on quality of life, both with all grades of hematologic AEs and severe AEs. And there really was no impact on quality of life in this analysis based on the EQ5D5L, the 5-domain component. No impact of hematologic adverse events on this patient-reported outcome. When looking at the FOSSI, again here on the left-hand side is the CTC-AE, reported nausea and vomiting, and on the right's the FOSSI scores. And so what you see are on the right-hand side, the dashed lines on the bottom of each of these graphs are the severe adverse events, which were quite low and not dissimilar to one another in terms of placebo versus niraparib. In the graphs with the bigger bubbles, the size of the bubble tells you how many patients participated in that quality of life or that PRO reporting. So one thing to note is that the participation was quite high. But what you also see is that you do see nausea. It peaks about cycle 2. You make appropriate recommendations for treating that, and we just had some wonderful guidelines presented today. And the nausea gets better, probably because of interventions, but also because the nausea ameliorates over time and exposure to the niraparib. And so we see reductions in nausea and reductions in vomiting with time. We can see the same thing with fatigue. These are FOSSI reports. I have fatigue or I have pain. This was pointed out already. If you look at the left-hand side for fatigue, so many of our patients coming off chemotherapy, 80% report fatigue. So this is very common, and pain is about 40%. And what you see in both of these figures is the grades of severe fatigue and pain are very low, but we do see some suggestion with fatigue that fatigue improves with time. So if you're treating someone with an effective therapy, even with a drug that causes fatigue, their overall fatigue gets better because you're treating their disease. And pain, similarly, we see reports of pain diminish. This was a secondary analysis, so we can't really say it's statistically significant, but we can say there's a trend towards improved pain with time on niraparib. And so in conclusion, the successful use of niraparib as a long-term maintenance depends on, number one, patient counseling and setting expectations and using appropriate medications so we can mitigate a lot of the non-hematologic toxicities and patients know what to expect. Number two is really emphasizing convenient dosing, making things as easy as possible for patient. And number three is really paying attention to the labs, reassuring patients that dose modifications aren't impacting on their efficacy, so they feel more likely to stay on, be compliant with medications, and get the benefit that this drug appears to provide. And we can do so with the confidence that by the tools that we used in NOVA, we did not negatively impair quality of life, so the benefit in PFS seems to be worth it based on what our patients are telling us. So with that, I thank you for your attention.